Neither the El Paso Medical Society, its members, nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. Pediatric surgeons, they diagnose, they treat, and they manage children's surgical needs, which are very, very different from an adult's surgical needs. It's a specialty that includes care of patients from the NICU up to 18 years of age. So think about 18-year-old, they look like adults, but there's a lot of special care that each one of them has. And Christina, who's joining us this evening, said, let's not forget about the parents. There's a lot of help that the parents need with this as well. As you know, this is a live program, so think of some questions you want to call and ask us about this evening. That telephone number is 881-0013. We are talking about high-risk newborn clinics and pediatric surgeries this evening, and we are underwritten by Tenet, the Hospitals of Providence. We also want to thank Texas Tech, the Paul L. Foster School of Medicine, for providing the students to man our phones this evening. And today I have to throw out a huge congratulations to Madeline Morris, because as of I think a week or so ago, she is now a second year in medical school. She is done with her first year, so congratulations, Madeline, and thank you so much for helping us out with the phones. So Madeline will be answering the phones and sending your questions our way. We also want to say a huge thank you to the El Paso County Medical Society, who has been bringing the show to you for almost 26 years. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. We're talking about pediatric surgeries. There's a lot of different things that can go wrong in little ones. We're going to talk very specifically about very, very young ones, even some newborns that are born a little bit too early, and then really extending all the way through until the age of 18. That's the entire genre that pediatric surgeries deal with. So we have with us this evening Dr. John Lawrence, who is the Section Chief of Pediatric Surgery at the Texas Tech University Health Sciences Center. He's also done some work with Doctors Without Borders. And then we also have Christina Zapata, who is a nurse, who is the supervisor of the Providence Children's Specialty Clinic. And so both of you, thank you so much for being here this evening. We think of little ones, and you know, when a baby is born a couple of months early, it's a big deal. A couple of weeks early, it's still a big deal, but a couple of months early, and this is where we're going to talk a little bit tonight. And I know that we look at a span of, well, just add a couple of more months onto that and things are good and better, but there are also things that follow these children going forward. So we're going to talk a little bit about that, and then surgeries in general with everything that has to do with pediatrics. So Dr. Lawrence, I'd love for you to start and just give us a brief background of who you are, why you came to El Paso, what do you like about here, what you have studied, and why is it that you like surgeries on little tiny little people?
All right. Well, thank you for the introduction, first of all, and for having a chance to be here tonight. To address your question or questions linked together there as they were. Talking first about my background in pediatric surgery. My career has been primarily in academic settings, much as it is here. So working in teaching hospitals, and the practice itself has appealed to me really from my first exposure to it as a surgery resident, and it was some of the issues that, or facets of it that you've already highlighted. It's a diversity in conditions, the variation in the age range and size of the patients, and I would say maybe in a way that's different than the adult populations that obviously whose care is very important, but they need to be connected to families, and the interaction, may be primarily to the patient, or it may be primarily with the parents or extended family, or it may be an interaction of all of those elements.
Right.
As to what brought me to El Paso, I think I could very honestly say that the real attraction was a endowed chair that exists at Texas Tech, what's called the Meyer-Mounsey Endowed Chair, which is pretty unique nationally, and a position that is geared towards providing opportunities for a pediatric surgeon to do not only pediatric surgery in a more standard clinical setting here in the U.S., but also to work internationally. And so So it's was set up in recognition of the work that Don Meyer, who was for people who've been in the community for many years, may have had contact with, but a pediatric surgeon who devoted a good portion of his practice to working internationally in Africa and doing a lot of charitable care, and then a family who he cared for here in El Paso that were very grateful for the care they received and set up this endowed position that I'm occupying. So it's an honor and a privilege to be here and assuming it. And as to what do I like about El Paso, I would say the cuisine is great.
It is.
And
yes.
hard to top. The I must say I'm a big fan of the proximity to open space near a major metropolitan area. So as somebody who loves to get out on the trails and the Thousand Steps Trail in that area, it's pretty unique to be able.
We have lovely mountains here, and
Absolutely.
more and more getting more bike trails and involved. So I appreciate you being here, and I agree, it's a place I never want to leave.
Yeah.
Yes, absolutely. Christina, I should ask you, are you from here? Did you also relocate to El Paso, or?
No relocation, I am from here.
Yay, I love that. So what do you like about El Paso? Actually, we do have to answer that question now that we've asked Dr. Lawrence that, but I also would like for you to explain to the folks at home what you do all day, every day, and how your position with pediatric surgery helps everyone that's involved.
Well, this is home. I'm very family oriented. We have a huge family, tons of kids, so we spend all day, every day with family and outside. It integrates into my job because I love the connection I make with the families. Number one is family and the child, and taking care of the whole family as a whole rather than just the patient.
Right. And I like when you said that when I was writing down some of these questions here, and I said, well, do we stop at 18? When is pediatrics? And I know in our head it's 18, but I know some 18-year-olds that look like 25-year-olds. So we were kind of joking about that, but I really like that you said that. It's not just the child, because you're looking also at siblings too. Because if someone who's very ill, there is a way to bring care home with all of that as well. So one of my first questions is, and Dr. Lawrence, I'm gonna bring this to you, and I'm just gonna go from very, very beginning stages up to the age of 18. So we have a pregnant mom, and pregnant mom is maybe 4 or 5 months pregnant. How does a person know, and I know that there's sonograms, they go through her checkups, etc. How does one know when there is an issue in a pregnancy, and just kind of maybe take us through a case study or two in your mind that you can think of, and what some of those issues could be pre-birth?
Yeah, well, and I think I might even, take a step back before, getting into the sort of the more specific details of that, and just highlight that I think that the expectation of almost any set of parents is that their child is going to be normal, and so we can't, as we are bringing in, as I think is entirely appropriate, sort of the emotional, social aspects of healthcare, as a subset of the patients that we deal with. Parents of a newborn who has been identified as having an anomaly have more stress, I think, than almost any of us can imagine, and I think it's important that we highlight that, because anyone who's been a parent knows how difficult it is with a child who's otherwise normal, and so that to kind of add on to that, a condition that one may not have understanding about, and/or what are the ramifications of that, is really a significant burden to be bearing. So. The identification process, though, typically does, as you highlighted, begin with a screening ultrasound that's done. And I'll be honest with you and say I don't know what the standard of care is, not being an obstetrician, for when that might be done. Obviously, there are circumstances where in the course of a pregnancy women may not be able to access prenatal care, so sometimes they're born with conditions where they're caught unawares, if I may say. And then related to that, it also, ultrasounds are also somewhat imperfect, and so it happens on occasion that a child is born with an anomaly and it hadn't been appreciated ahead of time. So all of those things can factor in. But if we talked about one in particular, and I'm just going to choose the diagnosis of what's called gastroschisis, which is a type of abdominal wall defect where the intestines are actually outside of the abdominal cavity for most of the pregnancy. so that immediately after birth, the child then needs to have a procedure performed to return the intestines back into the abdominal cavity, if at all possible.
And that's something that most likely, if there's sonograms, you can tell, and so there would be a pediatric surgeon at the ready, so to speak, at the birth of the child. Would that be correct?
Exactly.
Okay.
And so I would say, you know, perhaps not physically in the delivery room, but, you know, being made aware that the child was going to be born, and so, you know, in proximity and ready to take that child, you know, to the operating room more often than not, to then perform a procedure to get the intestines back into a contained space.
Okay.
So yes, this is the sort of thing that if it's picked up ahead of time, then often what's done is a prenatal consultation is arranged for the family, and that, you know, could include meeting, you know, someone like myself or my colleagues in pediatric surgery.
Right.
It oftentimes can include meeting with a member of a neonatology team or the team that would be working in the neonatal intensive care unit to care for the child afterwards. So, you know, to try to provide, you know, I think a more broader and encompassing approach to, you know, what it is that would be happening after their child was born and what the stay or the environment was, you know, might be like.
Right.
And, you know, that can include, and again, it varies from institution, but that could also include, you know, having a chance to tour the NICU before the actual delivery has happened, so that the parents, you know, can actually conceptualize, you know, what it is that, you know, that may need to be done, or where the environment is where procedures might be performed or care given.
And Christina, I'm going to kind of jump in here because I think this is where you might come in with the staff, because the years of doing this program, it's amazing to me the teamwork that has to occur. Not amazing to me, it's just, it's nice to see the teamwork that has to occur when anything goes down. So let's take this case as an example, that the mother knows that there's going to be surgery pretty soon after the birth of the child, and that they're going to have to be in the neonatal unit for a while, or the NICU unit for a while. You and the staff, talk us through how that would be. So talking the mother, you know, taking them on tour, and I know with the times of COVID, it's a little bit different than it was in the past. You know, for a while they were thinking we're trying to get back to a little bit normal, and now, you know, things are a little bit changed. So if you want to throw a little bit of that in too, I completely respect that. But the communication in general with the families.
So what happens is the patient, once admitted into NICU, I don't know currently if they're allowing families. There is a program where they would include siblings and grandparents into the care of the child. Currently, I'm not too sure who they're letting in, because we're just going from day to day.
No, I completely understand that. And maybe talk about what you would talk to the parents about, or to the mother, and maybe we can just look at now what we're talking to the mother about before.
It's an explanation of kind of what's going to happen, how long possibly the patient might be in NICU, what the procedure might look like, what their role in the NICU would be, because baby would stay and they obviously go home.
Right.
Concerns about
which
breastfeeding.
I think is a hard thing to explain
Absolutely,
to a brand new mother.
absolutely.
Right.
I mean, it's very hard to say my brand new baby is going to stay and I go home. It's very hard to comprehend what breastfeeding might look like. Can you still breastfeed? I think overall the care of the child, and then for them, it's a realization of what the next couple of months might look like.
Exactly.
Yeah.
Exactly.
Yeah.
So let's look at, there are so many different, and I know right before the program, Dr. Lawrence, we were talking about a lot of different types of surgeries that pediatric surgeons perform. So we were kind of talking a little bit about pre-birth, and now let's take a case that you might think of off the top of your head that you've treated before in the past that we didn't know that there was going to be an issue until the baby is now born. What might some of those be, and how would you handle that? And maybe look at some of the most common, and that way some people might recognize some of the wordings.
of conditions that we might not be aware of. So I could give an example. A condition called diaphragmatic hernias, where there's the diaphragm or the breathing muscle on one side of the chest, doesn't close properly in the way that it should, so it actually starts as kind of a peripheral rim of muscle that the ingrowth to kind of make a congruent layer should occur, and if that doesn't happen, that can then lead to the herniation or the movement of abdominal contents up into the chest cavity. And so with that circumstance, again, many times we're going to be aware of it antenatally and be prepared to deal with it, because those infants can be, quite ill at times. But conversely, you'll also see the circumstance where some cases aren't identified or picked up until the time of birth, and the child presenting then with some element of respiratory distress or difficulty in the first few days of life. Or it may be that they even go a few weeks or a few months into life before it's picked up, just kind of incidentally on a chest x-ray that may be obtained because they had a cough or for some other reason. And so it's an example of a condition that really can present anywhere along the way from we know ahead of time, and in the way that it's very odd. This is a case, the ones that we do know about ahead of time often have the worst outcomes.
Right.
And whereas the ones that present later, because they tend to be more minor, and or the child has adapted better to them, that they don't wind up having as severe a
That's interesting,
a
'cause you would think would almost be the opposite, that if you knew ahead of time that that's something you can fix. But that's a good point too. And Christina, I'd like for you to hop in on this too, but our bodies are amazing. I mean, there's a baby is born, and sometimes they can have issues with the heart. And I know that we're talking about cardiac pediatric surgeon, it's a whole different thing, but I don't know how often you have seen issues where a child has had some kind of abnormality, but nobody knew for weeks on end. And so I'm going to ask you, and I know this is a hard question, but what might be some symptoms or just some things that parents can look out for if my babies, feel like they're out of breath or this and that and the other? What is it that parents can look out for if they think everything is fine going home in the first place?
So it might not even be that they're not reaching milestones. It could be they look a little different. And to say different, I mean, it's very difficult for a parent to understand that. But they have differences that mom and dad don't have. A different chin, per se. It could be something simple as that they've caught before. It could be that they're not reaching their milestones. Some babies are a lot faster, some babies are a lot slower, but it could be something very minor that they're not reaching. It could be once they're starting to babble, they're not babbling correctly.
Okay.
They're doing repetitive movements. It could be something very not.
And this is where it would be very
common.
important to have those checkups where at first you think, man, and I remember with my two little ones who are 24 and 18, it's like, really? I have to go to the doctor again?
Yes.
And it seems like, first week and then 2 weeks. And those are some of the things too. And I remember breathing. I remember, how are they breathing? Color. Jaundice, for example, would be, and I know that's very minor. That's not surgical. I respect it. But just maybe gastro issues. I know that you were talking about gastro issues right before we started the program. Maybe bowel movements, if those are, I remember the first bowel movement of my child. I'm sorry, I'm going to be gross, but I thought she was pooping tar. I'm like, what is that? And I remember telephoning the hospital going, is this normal? So on that note, let's talk about just gastro issues, just the tract in the first several days or first several weeks. That, again, that baby's brand new, a brand new set of parents, maybe don't have other parents around. What is it that they could be looking for?
Yeah, well, and you've already, touched on a couple that I think are, probably worth reiterating or going back over specifically. So one that comes to mind is spitting up or vomiting, which again, all babies do, and it's a very common part of, I think I would just say sort of normal life with a newborn, and that, it's the white badge of courage as a parent that you have on your shoulder
I remember
after
those days.
after you burp them. But then, that can trend though into becoming, more pathologic to the point where, smaller children in this first couple weeks of life have more persistent vomiting, and there's a condition called pyloric stenosis, or a thickening of the end of the stomach muscle that often presents in a very gradual fashion, typically around, for a term baby, at around 2 weeks of age, but it can be a little bit earlier, it can be a little bit later, and just becomes progressively more of an issue, and easy to overlook. And in scenarios where grandparents will say, "Oh yes, you did the same thing. Don't worry, it's going to get better." Or
Right.
are you feeding him or her too fast or too much at a time or whatever it may be? But questioning about that new role of a parent that can come into it. And these are cases that sometimes are picked up within a few days of their onset, with a kind of a collaborative effort between the parents and the pediatrician or primary care doctor, family doctor. But other times they go weeks before they're picked up.
And then how is that diagnosed? So if they come in, what kind of tests are done to diagnose that?
Well, you're talking to a somewhat more senior pediatric surgeon, so I'm going to say the best way to do that is with a physical exam and a history, as we've talked about, so
Right.
you can actually feel this thickened muscle on
Okay.
exam. What's relied on today far more commonly, just because it's easy and accessible in the community, are ultrasound
Right.
exams.
Okay.
So that's the far and away
Good
the
old school ultrasound.
Yes.
So able to see all kinds of stuff.
Yes,
Okay.
exactly. So that would be an example. You mentioned jaundice. There's a condition called biliary atresia, which is a very unusual surgical subset that can account for jaundice. So
Okay.
again, for jaundice, babies, pediatricians, primary care doctors, family doctors are going to be following that, looking for improvement, and also potentially then trying to see exactly what the components are of what's called bilirubin, the compound in the body that causes jaundice.
I remember putting my baby in the sunshine.
Yes.
And that was
Well-
one thing that everybody's worried about. But then again, once you kind of go through it, you figure that out.
Yeah, but it can. In that particular condition, this biliary atresia, the bilirubin level typically continues to go up rather than kind of dropping back down, which is what's more normal in the vast majority of cases. And in turn, it can then lead to a need for a surgery ideally that would be performed at about 2 months of life to.
So what causes that to go up versus going down like it should? And then what does the surgery physiologically do to help bring that level down?
Yeah, so the surgery itself, which is called a Kasai procedure, it's named after the Japanese pediatric surgeon who invented it, is in essence a means of correcting the problem, which is sort of a progressive sclerosis or narrowing of the main bile duct. Combined with an element of intrinsic disease or dysfunction inside the liver itself. So it's kind of a two-pronged entity, I guess I would say. But the surgery that's done is to surgically replace the bile duct using part of the small intestine. So you relieve where the narrowed, scarred, obstructed element is, and allow the bile to then flow through a rather convoluted hookup of the intestines that probably isn't entirely pertinent to go into tonight. So that would be another example of something that comes up. And since you talked about bowel movements and your own experience with tar poop,
with tar poop,
exactly.
The tar poop is famous in our house. Yes, exactly. Yes.
Which once you get it on you, it's next to impossible to get off too.
Right,
It's
exactly.
really sticky.
I threw my pants away.
Yeah, yeah.
Yes, I did.
Anyway, the medical term for that is meconium, and there's some neonatal individuals wear badges that say meconium happens, and we'll kind of leave it at that. But this condition that's called Hirschsprung's disease is an entity where children aren't having normal passage of bowel movements. So we would say, that in the first 24 hours of life, the vast majority of infants are going to have passed that first stool, that meconium stool, on their own. By the time you get to 48 hours of life, it's only going to be a couple of percent of normal individuals that haven't passed a bowel movement by that point in time. So, so children who present with late passage of a bowel movement or in that neonatal period have what seems to be really excessive constipation. That this entity, Hirschsprung's disease, can be present, and it's important to be aware of because they can also get this condition called enterocolitis, or distension and inflammation of the intestines that can be rapidly lethal.
Right.
So we we and the healthcare team feel very need to be very vigilant on children and infants before they leave the hospital who might be potentially at high risk of having that, of trying to be as certain as we can be.
Oh, and Christine, I'm going to throw this your way.
Yes.
And I'm not sure how this works, but I know when a baby's born, pediatrician comes in, does the sure everything's fine. How specific is that? And I know this is such a general question, and I feel bad that I'm just like throwing general questions your way.
That's okay.
But to do a check in the hospital, because usually mom and baby are there a day if everything's on just fine. How does that, what is the pediatrician looking for with a new baby?
Really, the pediatrician is looking at a full head to toe assessment. Say they hear bowel sounds, they hear clear lungs, their eyes are okay, the fontanelles are okay, their hips are okay. Their pulses feel good, but the nurse is the one who's there for the first 24 hours. The nurse to also make sure that the baby has voids and stools in the first 24 hours, that the baby's feeding well, that the baby's not vomiting, that the baby does have the bowel sounds, the clear lung sounds. So although the doctor does come in once, it is also the nurse's job to monitor that baby every
sewed up and all that other good stuff. What is happening when baby gets whisked away? You know, again, I think a lot of things that you're talking about right now, yes, the doctor comes, and you're absolutely right. I mean, praise and adoration to all the nurses in the world, because front line, I mean, it's just happening all the time.
Absolutely.
And there's waiting, obviously, they get weighted, you're looking at color. What is happening during that time before they bring the baby back?
So they're checking baby's temperature, breathing, respirations, color, again, the bell sounds.
Again, yes.
Again, the bell sounds.
Yeah. And that makes sense, though, because that has to start working.
That has to start working.
Right.
They give it a little bit of time. They check their glucose. They do a number of things to just be sure that baby came out okay. Baby's not in distress.
Right.
Of course, if baby doesn't pink up, they have to put baby on oxygen, so that's always a very big concern. Does baby need any NICU?
Right.
So it's a number of things that are really of concern right as soon as baby's born.
Okay. And so, Dr. Lawrence, I'd like to maybe get older now, and I mean that figuratively. So I think we've covered a lot of baby, and just a little while we'll be able to go back to some other things that maybe we have missed. But what are some of the common surgeries that you perform on, let's say, children under 5 and then maybe children 5 to 10? Just to kind of, I have hernia written down here, umbilical hernias, or the possibility of one.
Yes.
I feel like that's something that I hear, not often, but I hear about with little ones.
Yes, yeah. So umbilical hernias is probably one of the more common conditions for children that get referred to us, in that, and I'm just going to sort of say 3 months to 3 or 4 year age range.
Okay.
And so they are a part of the normal process of development, or I might say a mild variation of the normal development process, where at the strong layer of the abdominal wall, the area where the umbilical cord had attached has not kind of fully cinched itself down, is maybe the best way I could describe it.
Okay.
And so they are prevalent. They are almost never a surgical emergency, but they certainly create, I think, a lot of concern for parents or families, because when children are agitated or crying, they will often bulge out. And the logical association of kind of cause and effect, my child is crying and unhappy, and this hernia is bulging out or present, I wonder if the two are related.
Right.
So,
exactly.
so a lot of concern expressed, but we typically, a good percentage of these that we see in our clinics will resolve spontaneously.
Great.
And
Okay.
so, you know, that's kind of the best surgery of all in the hands of a pediatric surgeon, is you don't have
no
to do
surgery.
anything.
Right,
Exactly.
exactly.
But a subset that then don't wind up closing spontaneously, and although there's variations in given cases. Usually, we wait until the child is in the 4 to 5 year range before suggesting that surgery would be done. Not that there aren't exceptions.
Okay.
Another kind of hernia would be the inguinal hernias or groin hernias.
Oh, yes.
So again, even though I think commonly those are thought of as something that adults get from straining or heavy lifting or being overly active, in children, again, it's just a variation of normal development processes. So a canal that exists between the main abdominal cavity and the genital region that nature should close down soon after birth, that persists in staying open. And so those, unlike the umbilical hernias that rarely create any urgent or emergent problems, with the inguinal or the groin hernias, there's a pretty high prevalence or potential for intestine to get trapped in those and take a sort of a more benign elective condition and turn it into an emergent one. So when we,
so this could be going on and the parents don't know, and the child is too young to say anything.
Exactly.
Until it gets to a point where it's so uncomfortable, I guess, for the child that they're...
Well, so the more typical sequence is that it presents as a bulge down in the groin region, and parents come in because they've noticed it, often at a diaper change in that age group. And so that's probably the most common way that they present versus as being something dramatic, with something actually stuck in it or what we call incarcerated in the hernia sac. Yes, but that's a very common procedure that we do preventatively to try to avoid the more emergent circumstance. So it's not something when we see it where we say, well, we need to drop everything that we're doing and get this taken care of, but rather...
So the digestive system is still working at this point, just not working at the optimal level.
So the digestive system shouldn't be affected by it unless the bowel has dropped in there and gotten caught, and then it can create a blockage of the intestines.
Okay, makes sense. Christina, I'm going to ask you a question, and don't laugh at me because it may not even be a thing anymore. But I'm an old lady, and back in my day, my baby brother needed tubes in his ears, and I felt like so many people needed tubes in his ears. And when my little one was young, she had chronic strep throat, ear infections, et cetera, and I remember that's a surgery. So I'm just throwing that your way to give you a turn to talk. And asking how common that is anymore.
Absolutely, very common.
Is it really? Well, then I don't feel so bad.
We had surgeries every Tuesday, Thursdays, I believe, sometimes Fridays, that they would come in, get their ear tubes.
Okay, and explain what that is and what's happening so that the tubes in the ears or just the normal tubes are not slanted the right way. Just explain how that
It could be from chronic ear infections. It could be from a lot of sinus infections. Overall, they find that the patient just continues to have some sort of infection, or they, correct me if I'm wrong, born breached, and they have water in their ears.
Oh my goodness, didn't even think about that. Yeah, that makes sense.
I was just going to add, I think that, as we're, talking here on the show tonight overall, this is I think a great example of the value of preventative care. So as surgeons, we're sort of action oriented, and we want to do things, and but so much of what's important in healthcare are preventative measures, and really the value of ear tubes is releasing fluid and or to prevent recurrent infections so that hearing will develop normally. So that is one of the the major values of putting tubes into the ears, and as I say, I think that it's yes, the children are very unpleasant. Anyone who's ever had a child who's had an ear infection knows the misery associated.
The screaming.
Yes, with that.
Absolutely.
But it's that much more the long-term perspective, I think, that the value of those procedures provide.
Yeah. I'm just looking at some of these notes here. Then we already talked a little bit about Peyronie's disease, or did we? That was when we were talking about the intestines, correct?
We haven't touched on that. So
so let's talk about that, because I know we're starting to. Time's going fast. It's amazing.
Yeah. So pilonidal disease.
There you go.
Is a condition that affects the region over the tailbone or by the gluteal cleft.
Okay.
So, without trying to be, too particular or as to exactly where that is, but I'm sure the audience can well understand. And the pathology or the basis of it somewhat poorly understood, but it certainly seems to be implicated by kind of turning in of the skin that may have occurred there developmentally and or irritation of hairs that are in that region and of course elsewhere in the body as well.
Right.
But as a major factor that may sort of, for lack of a better phrase, kind of stir things up. So it can lead to sinus formations or sort of little open tracts that drain fluid. It can lead to, much more significant infections. And it's something that I would say really see in adolescence, in the pediatric practice. So it's not something a 4 or a 5-year-old is going to be
And that's
getting.
something that is developed of no fault of, that's just something that's hereditary?
Exactly.
Okay.
Well, it's hereditary and or I would just say,
Just a formation
to some degree, more, I might even use the word phrase, a random event. The population that gets it, we don't really understand precisely, why they do.
And how are you able to correct that?
Well, so there's a variety of means. Sometimes, relatively simple procedures where you can actually sort of core out the areas that are diseased or involved. I'm just trying to think of, a common device that's around, but it would be a good analogy to it. But almost like soil samples are taking, you kind of core out that particular area that's involved. Sometimes it requires drainage acutely when it's infected, and then a more extensive reconstruction later on. There's a variety of procedures that can be done, and in really severe cases, it can even involve the need for plastic surgeons to be providing flap coverage or moving. So it can be in the more severe circumstances. It certainly is something I think that shouldn't be underestimated into how significant it can be. But by the same token, sometimes it's we're fortunate in that when it presents, it's in a more
So on that note, when it presents, say in the very beginning of presentation, so to speak, what is it that, for example, the teenager, let's say it's someone who's 10, 11, and mom and dad aren't, he's showering alone, he's doing everything alone. What are they looking for? Are there, other than physical symptoms you can see, are there other issues that they're having immediately? Is there pain? Is there abscessing? Is there,
So it can be, I think I would say a variety of those things, but I think a good point that you brought up, and the age range, again, is probably going to be post-pubertal in general. We're not going to see this.
They want their privacy, is what I'm saying.
They want their
mom
privacy.
and dad aren't going to be seeing this.
Exactly. And so my body is my body and not your body is part of the way, again, that is the expectation or the norm in that age group. So, they often are probably, late to present to us just for what you're highlighting, and that, a teenager is going to be embarrassed to say, Mom or Dad, can you look at this? I don't know what's going on. It sort of gets, swept under the carpet, as it were, but it could be pain in that area. It could be drainage of purulent or material or pus. Those are probably the most common ways, spreading redness or significant infection as time goes by.
Right. So that's definitely something you want to try to catch before it gets to that point. I have down here too, and this is interesting to me, so vascular and lymphatic malformations. In my head, I'm just thinking, that is such a freeway inside of our bodies. The spaghetti bowl times the spaghetti bowl times the spaghetti bowl. So some of those malformations, what could they be, and then how are they able to be surgically fixed? Because that seems like a handful there.
So you've asked a question that I could easily spend, the whole next hour trying to answer in truth. So it's again, there's a wide spectrum of conditions. I think that one of the more common things that families are familiar with are little sort of what are hemangiomas, or sometimes referred to as cherry hemangiomas, little bulges that have a red appearance, and often newborns and infants will have those, or they're either not appreciated at birth or very subtle, and then there's growth factors that the body elaborates that causes those to become more prominent. So they may then sort of blossom or bloom in size, and conversely, by 2 years of age, in some cases, those growth factors have then diminished to a level where that growth will then involute on its own. And so depending on where it is, many times it's better to not do anything surgically. But there's a whole category of classifications, and in this mixture of blood vessels and lymphatics, they can present externally, they can be inside the body, and manifest in a whole variety of different ways. So it's hard to provide a succinct answer to you, but I would say one of the things that's really evolved, and I think that's been exciting in this field, is the combined approach to those, using services that include sometimes medications will help, but also agents that interventional radiologists may be able to provide and inject into them through very select and specific pathways. And so surgery has become, I would sort of say, the default option after all else has failed, or there's something more significant that needs to be addressed. But many times, the need for the surgeon is actually to be involved as part of a bigger care team that are looking after these kinds of abnormalities or anomalies.
So we did a program not too long ago on pediatric interventional radiology, and it was fascinating to me, and I feel like there is a lot of cross-training, or that that's just naturally happening. With that in mind, when we're looking at old school surgery, and when I say old school, like 50 years ago, you're cracking chests open, this and that and the other. And with interventional radiology, we're talking a lot about the sonograms, but in general, do you as a surgeon use any interventional radiology, or is that something that's kind of done, and if something isn't working well, then they go pass things on to the pediatric surgeon? And that may be something that's still kind of in a world of mixing and melding together. I'm not sure.
Yeah, I think the best way to answer the question would be to say to some degree it's a combination of all the points that you made. So there are cases that are clearly best served by the interventional radiologist. There's cases where clearly, us working collaboratively with them makes the most sense. And then there are cases where it's pretty clear that probably the surgeon should be the one involved addressing the problem. And each case is unique and different. The variety of conditions that we have overlap with is very extensive. One of the more common ones being after patients have had appendicitis and perforated appendicitis.
That was my next question. That was going to you. So.
Yeah.
On that note, Christina, I was thinking to myself, appendicitis. I hear that all the time, and I don't know if I hear it more often in pediatrics, or is it just more excitable because it's someone who's a child? But I would love to ask you, because again, front line, there's surgery, but then after line, if someone has appendicitis, what are they feeling? What are the symptoms? And how do you know it's that versus just a really bad stomach ache, or et cetera, et cetera? It's hard. Again,
that is very hard.
Yeah.
Sometimes a patient might be throwing up. They have stomach pain. Sometimes it's just very general, and they'll say, my stomach hurts. The parent might think that they have a bug, and they'll say, okay, we'll just write it out. They have diarrhea, they're throwing up, a stomach bug. The pain continues. Sometimes they bring them in, and the doctor might agree it's a stomach bug and send them on their way, because they don't have the symptoms to diagnose them. Usually it's the right-sided pain, lower right-sided pain, but they might not present that way.
Okay.
Especially with little ones, it can happen under 5, and those are usually really bad. But since they can't vocalize, it's really hard to.
Yeah, that's the hard thing.
Yes.
If a little one can't tell you exactly what they're feeling.
Sometimes coming in through the ER, they'll automatically do an ultrasound, and again, that's how it's diagnosed. Usually,
that's the big question.
Sometimes it goes to a CT, correct? But it's not always diagnosed right away.
Okay. And to define appendicitis, it's the inflammation, it's the infection. What is happening with the appendix? Because people say you don't want it to burst. That's the big thing. So it's an infection. What is it that happens to get to that point?
Yeah, so the underlying cause, well, the appendix, backtracking, because many people in the audience,
And
I'm
why
sure,
do we
are
have it if we
familiar
don't need
with
it?
it. Yeah, yeah.
Right.
But it's like a finger that protrudes off the beginning of the large intestine, or the right side on the right side of the colon, and its function presumably is that it's very much involved in kind of lymphatic, immunogenic processing, I guess I would say, of the GI tract. But yeah, we again not digress too much onto that. What can then happen is this one of sort of two things that we think of as being the pathophysiology. Either the lymphatic tissue in the wall swells in near where it joins the large intestine, or some object or something in the way of a more solid piece of fecal matter forms, or it can even be parasites that can sometimes be causative, or even tumors, not very often in children, but something is sitting by the opening that obstructs it.
Something that's foreign.
Exactly.
Okay.
Yeah, and then what happens is the bacteria that are in the appendix are multiplying, and mucus is being secreted into the lumen or the center part of the appendix, and there's no place for it to go. So that then causes the appendix to start to swell, where if enough time goes by, it then bursts or ruptures.
Right.
Yeah.
Goodness gracious. We're kind of at that point now where we have about 12 minutes left in the show. So what I usually try to do at this point is stop all of these questions and kind of focus on what you all would like to talk about before we wrap up. And so would you like to go first, Christina? You're welcome to throw that over to Dr. Lawrence if you'd like.
I will throw it over to him.
I figured you would not, and that makes sense to me. Because I know that I'm interested in this Doctors Beyond Borders, or Without Borders. I know that you've been working with this for a while too. And I'm not super familiar with it, although I've heard a lot about it, and I think it's a fantastic program, but you've been working with this for quite some time. And would like for you to just talk a little bit about that.
You bet. And I'm going to take the opportunity to digress for just
Okay.
1 minute before
sure.
we get into that. And just say, first of all, I'll be, very upfront and honest. I've never watched your show before, and so
for shame.
Being new to town, I don't know why that
Well,
wasn't.
it's the show I have to give credit to the El Paso County Medical Society. I mean, they're really
Yes.
the ones that have been doing this for many, many years, and then PBS El Paso. I'm just a girl that asks the questions.
Yes.
So, but I learn a lot.
Yeah,
from being here.
but in that regard, I think it's fabulous without knowing what the format typically is. But that we're highlighting the nursing profession here in this discussion this evening, because because Christina kind of, I think I would say, was talking like about the newborn assessment, but the fact of the matter is the hard work done in the trenches in healthcare is done by nursing
Absolutely.
personnel, and nurses like Christina, nursing assistants, aides, and a whole variety of people that work in that umbrella. And we shouldn't be leaving out respiratory therapists and pharmacists and
Absolutely.
people who provide the stocking and the cleaning, which obviously has become critical here in the time of COVID. So this is very much a team venture, and I think it's fantastic to highlight, but to give credit to non-physicians in healthcare, because they are really what keeps the engine running, so to speak.
Agreed.
So
Good for you for doing that.
Well,
yeah.
the lead-in, why did that come to mind? Because Doctors Without Borders, which I'll talk about now, is an organization that's existed. This is actually the 50-year anniversary of its funding.
Wow. Okay.
And it's really an organization that focuses on responding to crises, and what does that include? That's natural disasters, outbreaks of infectious diseases, so Ebola being one
Exactly,
that there's
right.
been a lot of response to. But it also includes what I would say might be considered more chronic problems. So things like malnutrition, lack of vaccinations, the need for attention to specific neglected diseases, so or underserved or under conditions that haven't received enough attention, things like HIV being another example.
Exactly.
And then the surgical arm, which is what I know about, includes oftentimes responding and providing surgery in conflict zones or areas where there's, it may not be a formal warfare, but, instability that leads to lots of traumatic injuries. But includes also pediatric care and their programs, obstetrical care. So it's really
just areas that don't have a lot of access to medical care in
but
general.
exactly.
Correct.
So
Okay.
it's designed to serve underserved populations. And
Right.
if I can again add and editorialize a little bit, as somebody who feels strongly that healthcare shouldn't be a privilege but should be a right for all of us.
Absolutely.
Their focus is on the segment of the population globally who often have no care. So as we're talking about some of the various nuances of conditions that we treat here, I think it's important to recall that there's 5 billion people globally that don't have access to safe and effective and affordable surgical care, as
Right.
an example. So,
Right.
the organization, I think, very much is, a big part of their of their goal or reason for existence is to be able to try to, in a small way, correct that imbalance and direct resources to those populations that otherwise may not have the ability to have health care.
Especially in surgeries. I know that there are more apt to have clinics and people who aren't trained necessarily in surgical, and that again is such a specialty. So in Doctors Without Borders, what are the main trained physicians? Are they internists? Are they, again, surgeons? I feel like that would be a relatively rare deployment, so to speak, for Doctors Without Borders. Just in general, what kind of doctors, specialties does that attract?
So the most valuable physicians are people with broad training,
Right.
so generalist is what I would say. So who does that include or incorporate these days? So, I think I would say family physicians are well suited because they can do pediatrics and adult care and obstetrics and, some basic trauma care. Emergency room physicians is another
Right,
subset
exactly. I
because
imagine
they
that'd
have
be
this
huge.
same skill set and deal with acute problems well. But internists, obstetricians and gynecologists, pediatricians are also valuable. And then there are some specialized projects they have that really focus on what might be very surprisingly discrete subsets. I've spent a fair amount of time in recent years working in a project in Liberia that is partly involved with pediatric surgery, but the other main component of it is actually dealing with patients with mental health disorders and epilepsy. And because medications often aren't available for these patients, they are shunned from society and not able to function in a meaningful way.
Right.
So it's the need for somebody who has specialty in seizure treatments or for psychiatrists and other people with mental health backgrounds is another very important element of what's provided.
That's a
Yes,
big
yes.
thing. When you came to El Paso, and I know that we were kind of talking about this earlier, you'd been in several different countries. And are there different specifics in different countries that you have noticed? And you were talking about war conflicts, and then there's also countries that are not in any kind of a war conflict, but just simply do not have access to care because of their rule. How do doctors know where to go? And I know that there's a system, and I know you served on the board for a little while, but that's always curious to me. Is like, how do we know? How does the world know? And how does the doctor network of Doctors Without Borders know where to go and what's needed?
Yeah, and once again, I think I might phrase that as an extremely pertinent and almost provocative question in global health these days. So I think versus, I'll just say, 30 or 40 years ago, where the mindset was very much we know best as the outsiders, interlopers for what it is that you need. Now I think the orientation is much more a collaborative system whenever possible, where the given country is acknowledged as being the expert on what the healthcare needs and environment and pros and cons are in terms of what they can provide or can't provide. And so that integration with what is already existing has become an extremely important topic in, I'm just going to sort of say, in humanitarian or charitable care overall, and not just within Doctors Without Borders. So it's hard to kind of answer that. Each circumstance is very different.
Yeah,
and
every land, every country has
yes,
their own.
and
Okay.
and if you have an armamentarium where you say, do we select TB care or infant mortality or HIV or
Years ago it would be polio, which is almost eradicated now.
Yes, I think I would just follow up on that very quickly though with having an orientation towards public health. Preventative services are really where the most important things are. So immunizations, and as we're talking about
Big
the
time.
COVID
Yes,
vaccine right
exactly.
now,
Right.
how vital that is for preventing various diseases. Clean water and sanitation, fundamental element of well-being overall. Secure sources of food being another part of that. So it's basics that make a big difference.
Okay, and when you said the fundamentals too that we take for granted all day, every day. So I appreciate you doing that. I appreciate all your colleagues that do that. Christina, I have to say huge adoration and praise for you being here. And again, take that back to all the nurses and really to everyone that's on the team. And I really appreciate you saying that it's not just the medical doctors. It really is everyone down from, the guy that's looking for Clorox wipes, to clean everything up.
Absolutely.
So it's been that kind of a year and a half. I know that we as the El Paso County Medical Society, PBS El Paso, again, we are really encouraging people to get vaccinated for many reasons. And I know that there are, we're not telling you what to do, but it is definitely strongly encouraged on this end to help out with the variants that are going on right now. And again, you are better protected, and for sure, not necessarily of getting it, because I know that there are news stories too, but to prevent severe disease and hospitalization. So it's a big deal. If you want to watch this program again or any of the programs that you have seen here on PBS El Paso with the El Paso County Medical Society and the El Paso Physician, you can go to two different places for that. You can go to www.pbselpaso.org, or you can go to the El Paso County Medical Society website, and that is www.epcms. Just think of the acronym of El Paso County Medical Society.com. And Madeline Morris, again, thank you for being here this evening. She is in her second year of medical school. Congratulations. That is brand new, but the first year is always that hard year. So we appreciate you being here. So we've been talking about surgical pediatric procedures, and again, it's been a delight to have both of you here. Thank you for choosing El Paso. Thank you for staying in El Paso. That's a big deal, and we want to thank everybody out there. Again, the El Paso County Medical Society, who's been doing this forever, Tenet Healthcare and Hospitals of Providence. I'm Catherine Berg, and you've been watching the El Paso Physician.